Hello, my name is Daniel Herron. I'm from Sacramento, California, and I'm going to talk about ultrasound screening and some things I've learned over the years on how to do it and how not to do it. I've been doing ultrasound screening since 2013. So if you're interested in either learning ultrasound screening or already doing it, hopefully this will be of some value to you. I live in Sacramento and I tease about all the funny signs I see. This was a sign in front of a spa that's like 3 feet deep, warning you not to dive. And I thought that was funny. There's actually a baby pool next to this, which is also like 3 feet deep. And I saw someone dive into it not too long ago. They didn't get hurt, but there was no sign next to it. So I guess they also needed a sign next to this. So let's get into this. I don't have any financial disclosures. This is a young Benjamin Franklin, doesn't look the same as on $100 bill, but he said an investment in knowledge pays the best interest. So I'm glad we're all here trying to learn new things, and thank you for listening. Um, there was a nice paper that came out a few years ago from the Netherlands about how it's important to find breast cancer early. I had a large number of patients involved, 170 some thousand, and they treat cancer very similar to us. They treat it with similar chemotherapy, similar surgery. They screen for breast cancer. Sort of a busy slide, but basically, if you can find cancers less than a centimeter in size, their survival rate was essentially 100% and even 98% up to 2 centimeters in size. Sort of funny. Their ductal carcinoma in situ patients, this is relative survival compared to an expected population. It was actually with ductal carcinoma in situ, it was 101% survival, which sounds crazy. But I think it wasn't a statistical blip. They had a theory that some women who were told they had an early cancer actually changed their lives. They ate better, they exercised more. So, in a weird way, getting an early cancer was somewhat helpful. But anyway, this just points out how important it is to find small cancers. And that's what we're trying to do by adding ultrasound to mammography. I was in the Netherlands with my son, actually, and we got lost, and which isn't a problem, except he knew where the hotel was. And I remember this kiosk where people had connected little boots and mittens that people had lost. And so I worked my way back there, and someone had found my son and connected him with that. So we got together and had a lovely time. Um, Basically, we're trying to find cancers in people with dense breast tissue. This is an example of someone with very dense breast tissue. And I'm sure many of you are like me. If I say her mammogram's normal, I'm not that reassured. You can realize how much can be missing in this mammogram. And statistically, if you send out 100, or excuse me, 300 normal mammogram letters, probably one of them may have a cancer there that could have been found with some other technique, either ultrasound or MRI, or if you do contrast mammography. But not everybody that gets a normal mammogram report has normal breast. Um, so I'm not going to spend a lot of time showing the data of screening breast ultrasound, but just summarizing a bunch of studies. If you do screening breast ultrasound, this is in women that have had a normal mammogram, you'll find about 3 to 4 additional cancers per 1,000 screening ultrasounds, or about a 40% increased cancer rate. Most all of these will be invasive, most will be node negative. There was a study showing you can lower your interval cancer rate with screening breast ultrasound. And a lot of people are using interval cancer rate as sort of a surrogate for lower mortality and also to review the quality of your screening program. You can also get your positive predictive value of biopsies, meaning how many of your biopsies are actually cancer. You can get it over 20% with ultrasound, just like you can with mammography and MRI. So, in my opinion, screening ultrasound adds a lot of value to people with dense breast tissue and a normal mammogram. Uh, Again, in the Netherlands, there's a painter named Rembrandt, and this is one of his paintings. This is actually the only painting he did of a seascape, and actually in the middle at the bow here, excuse me, at the stern is actually a self-portrait. This is Rembrandt himself. This is Jesus in the back. This is, I think the painting was called Calming the Seas. I'm not sure if he already calmed them or they even looked worse than that. This painting was actually stolen from Boston on St. Patrick's Day in 1990 from a museum and has never been found. So maybe it will show up eventually. But anyway, there's still a lot of headwinds for ultrasound. It always shocks me why we're not doing it everywhere, despite all this data that it works and you can find early cancers. Recently, there was a study out of, I think, the University of Washington, another study showing how effective ultrasound is. They had 1,000 average risk women with normal mammograms. The physicians themselves actually performed the ultrasound, and basically they found 4 extra cancers per 1,000, all node negative in women with dense breast tissue, and basically got 100% sensitivity. And there were no interval cancers after 1 year of follow-up. So I was like, okay, another study showing how effective ultrasound is. But in the very same issue, another radiologist from the University of Washington said, well, basically, we shouldn't be doing screening ultrasound. This study just shows how it doesn't help. And I was like, oh my gosh, that's not how I read the study. But he was sort of focusing on some of the data, which was true. There was data showing in women with negative findings at mammography, adding ultrasound required 55 additional recalls to find a cancer. That is a lot of recalls. In women with non-dense breasts, there were no cancers found. Well, most of us are not doing ultrasound in people without dense breast tissue. And the recall rate went from 8 to 30%, which is too high. And their positive predictive value was 5%, meaning they had to do 20 biopsies to find 1 cancer. Again, all these statistics aren't perfect, and I think they can be improved upon. And he did, conclude that MRI and contrast enhanced mammography is better for finding cancers, which may be true, except all those things require other things like contrast. Iodinated contrast can have reactions. MRI is expensive. It's not accessible to all women. So I think we can use screening ultrasound. We just need to do perhaps a better job of it. At that point, I was banging my head. A colleague of mine has this on a wall of one of our offices. I didn't think it would come in handy, but actually comes in more handy than I thought. So I see the glass half full with beer when I look at screening ultrasound. Basically, it helps find additional cancers. We just need to find those cancers with as few recalls and biopsies as possible. So let's talk about some ways we can do that. So first off, it's important to choose who's going to be reading these screening ultrasounds. There's quite a learning curve. It probably takes 50 to 100 cases before you sort of get a hand of it. You want to choose a few readers who are interested and skilled in breast ultrasound because you want to keep your recalls 10% or less. You want to not have a lot of BI-RAD 3s. And you don't want to biopsy everything. You want to keep your positive predictive value on your biopsies over 20%. And this is all achievable. So in my practice, we identified 4 readers and 3 of them are still left. 1 of them retired. 2 of them don't do a lot of reading. It's mostly me, but I think it's been helpful in limiting how many people you have in your practice do this. It's also important to choose your patients. This works better for certain patients than other patients. In my experience, the denser their breast tissue, it tends to work better. So the more white glandular tissue they have, you're looking for these little hypoechoic tumors in the middle of the white tissue, the better it is. It works better in women with average to small breast size. I think it works really nice if they have retropectoral implants. It's almost like the implant provides a nice hypoechoic background to the breast tissue. Sometimes I do an ultrasound for diagnostic reasons on people with dense breast, and you can just see through their glandular tissue so beautifully. And at that point, I'll commonly mention to them, you'd be a great person for screening ultrasound. I'm sure all of you have looked through women with dense breast tissue, and there's all this artifact, and it's still hard to see. So it's interesting how some glandular tissue is easy to see through and some is hard to see through. I think it also works beautifully in people with lots of cysts and fibroadenomas. Their mammograms can be so busy, and you can just see all these little things beautifully with the ultrasound and look for one that looks different. A friend of mine from a big company shared their data on like 100 million images. And I don't know if you're interested, but this is in the US. The average breast size is about 890 cubic centimeters. The range was up to like 5,200 and down to 30 cubic centimeters. In my experience, screening ultrasound works best at about 1,000 cubic centimeters or less, which most of you may not know. I just happen to have breast density software that tells me their breast size. So that's somewhat helpful in choosing my patients if I'm able to. This was a nice example of a patient who had very dense breast tissue, and her cubic centimeters of her breasts were like 180. So she had very small, dense breast. And we could see beautifully, this is an automated axial view of her breast. In the center is her nipple. And you could just see through her dense tissue beautifully. This is a rib and chest wall. So the other thing is important to realize is that screening exams are not diagnostic exams. And most of us, all our experience with ultrasound is diagnostic. So you need to realize your pre-exam risk is low. I mean, most of these patients are at intermediate risk or low risk. You're only going to find about 4 cancers per 1,000 exams. This compares to if you call back patients, you're probably going to find about 50 cancers per 1,000 exams. Or if they come in with a non-painful palpable lump, you're going to find about 100 cancers per 1,000 exams. And you're going to see lots of things on these ultrasounds. You just can't call everything back. You can't biopsy everything. So you got to be a little bit choosier and have a different threshold for what you call people back for. Ultrasound abnormalities are common. Specifically, you're going to see lots of cysts. And the more I do this, it's almost unusual not to see a cyst in most patients. At least half of patients you will find a cyst in. You see cysts more in premenopausal patients. You see them more on patients taking estrogen, but even almost half of postmenopausal patients have cysts, and a lot of people, they're bilaterally. So your classic cyst will be anechoic, oval, parallel oriented, circumscribed, post-acoustic enhancing. And these show up very clearly on the ultrasound screening equipment I'm using. You're also going to see lots of complicated cysts, probably about 15%, 1 in 8 examinations, which is basically a cyst that has some low internal echoes. Usually you don't have the wall seen, it's thin. Again, may have posterior acoustic enhancement. If you see multiple of these, you can use the rule of multiplicity and just call it benign. If you just have one in the breast, oftentimes this will be a common reason to call back patients. You're going to see a lot of clustered microcysts. So these are little cysts with thin internal septations. They're on the spectrum of fibrocystic disease. They occur in the terminal ductal lobar unit. And again, these will be frequently seen in breast tissue. And we'll talk a little bit later about, should this be a BI-RAD2 or a BI-RAD3 lesion, but it's a common reason to call people back. Fibroadenomas are common. They're going to occur in about 15 to 25% of examinations. Commonly, they're multiple. And on my ultrasound equipment, I can, oftentimes clearly see a very circumscribed oval hypoechoic mass with or without post-acoustic enhancement. And sometimes, I can see it very well. And to be honest with you, I don't call all of these back, but it will be a common reason to have them come back and recheck it with a diagnostic handheld exam. So how do we limit these callbacks? Because if you're calling 20, 30% of your patients back, it's going to get old. The patients are going to get upset. The referring doctors are going to stop sending you patients. So you need to be careful of how many patients you call back. One way to avoid this is to ask the patients to just wait there and try to read it while they're there. It turns out with automated equipment, If I see something abnormal while they're there and I go in and do a few handheld views, that's not considered a BI-RAD 0 exam. If I clear it, then I can just dictate it out as a BI-RAD 1 or 2. So that's my understanding of how the rules work. So that's sort of a nice thing to keep your BI-RAD 0 rate down, and the patients are happy that they didn't have to drive back on a different day. It's important, depending on what equipment you're using. If you're using automated equipment, frequently you're going to get multiple views of the same breast with overlapping images. So a lot of times I might see a lesion on one view. This is the AP view where the compression's directly over the nipple. And I thought I saw a little mass over here, but there's going to be more compression on the lateral view. So on the lateral view where it's compressing right over this, there was absolutely nothing. So this was just basically seen because of the tissue was not compressed. So typically, if it should be seen on 2 views, you want to see it on 2 views before you call them back. The other important thing is I always compare, if they're here for a screening mammogram or screening ultrasound, I always try to find their mammograms and compare them. I've decided, this is my own rule, if you have a recall rate of X with mammography and a recall rate of Y with ultrasound, the total recall is not going to be adding them together. It's probably going to be less than either one of them, because you can limit recalls from mammography if you have the ultrasound, and you can limit recalls from the ultrasound if you have the mammogram. So it's important to compare them. This was an example of a screening ultrasound where I saw the ultrasound before the mammogram, and basically there was a mass. This is their nipple. There was a little mass above their nipple. This is the axial view, and this mass, looks worrisome. It's hypoechoic. The margins aren't very clear. There's a little bit of shadowing behind it. But when I pulled up her mammogram, she had this huge, chunky, dystrophic fibroadenoma in that same location. And so basically, I wasn't going to call the mammogram back, and now I wasn't going to call the ultrasound back. This was a case, again, where I looked at the ultrasound before the mammogram, and I could see this nice cyst. So this cyst, met my criteria, was essentially anechoic, thin-walled, imperceptible wall, post-acoustic enhancing. And then I pulled up her mammogram. It was actually her first baseline mammogram. Doesn't show up very well here, but she had a mass in the left breast laterally, which was pretty circumscribed, equal density to the breast. Now, if this was her first mammogram and I didn't have an ultrasound and that's the only thing I saw, I guess depending on the day of week, I probably would call her back just to make sure that was a cyst. But I already knew it was a cyst on the ultrasound, so I didn't call her back from her baseline mammogram either. There's going to be lots of ultrasound artifacts. If you do ultrasound, you're familiar with these. Some of these are unique to the automated systems available, and some of them are just general ultrasound artifacts. So in general ultrasound, it's really hard to see behind the nipple. And my automated equipment has this algorithm to try to clean this up, and it works beautifully a lot of the time. I mean, I think this is her nipple here, and I think that you see pretty good behind this. You're not going to see this good behind it a lot of times with handheld views. This is an example. But depending on, I might not see it on one view behind the nipple with a lot of shadowing, but see it pretty good behind with another view. So I'm looking at all my views, trying to clear the nipple. To be honest with you, sometimes you just can't see behind the nipple very well, and you just have to bring them back for some handheld views. This was a nurse who was there, and she waited for her results. And so I basically just went in and got some handheld views. This is the handheld view I was able to clear behind the nipple, but I never was quite able to clear it with my automated equipment. There's this thing called air contact. Basically, air gets between your transducer and the breast, and you get this squared off area that's hypoechoic. And this can happen with handheld also. A lot of times I'll have another view where I can see this part of the breast, but if it extends over a centimeter, centimeter and a half, you're looking for a centimeter cancer, it certainly could obscure that. So sometimes you just have to bring them back if you can't convince yourself you see it in another view. There's this thing called wandering shadows, which is sort of unique, I believe, to automated systems, but basically as the beam hits these little Cooper ligaments, as it's moving over them, you'll get these little peaks of hypoechoic behind these Cooper ligaments, and you get sort of used to these. You see these all the time. Sometimes they're less apparent on the sagittal views or coronal views, and you can clear it. But if there's just one particular one, sometimes you have to call them back. But you just sort of get used to seeing these and learn to work your way through them. This peripheral shadowing is, they set up an algorithm on the software to not view things that are not compressed or viewed well. So you'll see these, just cut off of the breast. And usually there's another view that will show you this part of the breast. So this usually isn't a problem, but this isn't really an artifact. It's actually designed into the system. You will also get this sinusoidal pattern, and going back, where you get these waves. This is a coronal view that comes with the software, which I actually like the coronal view. This happens oftentimes because the patients are breathing heavily or they're thin. And again, you sort of get used to seeing this artifact. It's not probably showing up very well, but we try to have the patients not talk or slow down their breathing while we're doing the examination. You can actually use the artifact to your favor. This is a coronal view. You'll see these areas of white. This is basically the area of posterior acoustic enhancing behind a cyst. So this white here is this white here. As I come out more superficially, I'm going to see the cyst on the axial view. So can use this to your favor. It's usually a sign of a benign finding. However, you can have cancers that have posterior acoustic enhancing. This was a high-grade breast malignancy, almost looked like a cyst, had posterior acoustic enhancing, but actually was a malignancy. So it's not always a sign of a benign lesion, but it can be very helpful. On the other side, the posterior acoustic shadowing is helpful to find cancer. This has a high positive predictive value with malignancy. And on the coronal views of my automatic equipment, I'll look for these black holes, which actually is the posterior acoustic shadowing of the mass. So this is helpful in distinguishing a malignancy from a benign lesion. So let's just talk about quickly how what our BI-RADS-3 follow-up findings should be. The BI-RADS 5th edition lists 6 findings that qualify for a BI-RADS-3 lesions. I'm going to start with the lesions that have the most data that are reassuring they are BI-RADS-3 lesions. As we go farther along, there's less data and more based on expert opinion. But basically, the most data is a oval shaped circumscribed solid mass, which is essentially trying to describe a fibroadenoma. In fact, in women under 40, there's a lot of data that this is a BI-RADS-2 lesion. Over 40, there's less data, and so oftentimes this will be a BI-RADS-3 lesions. However, to be honest with you, I commonly will call this a BI-RADS-2 lesion if it's very convincing and meets all the criteria. Again, I can't be following up and calling every patient back on these screening exams with a low pre-exam predictive value for malignancy. The second BI-RADS-3 lesion is an isolated complicated cyst. I happen to know this was a complicated cyst because she wanted it aspirated and it went away. But again, you can use the rule of multiplicity. If you see multiple of these on both sides, at least one on each side, you can turn this into a BI-RADS-2 lesion. And in fact, there's quite a bit of data that the cancer rate is very low, and Dr. Berg favors using this a BI-RADS-2 lesion. She's out of the University of Pittsburgh. In terms of clustered microcysts, these little small cysts with thin septations, in the BI-RADS 5th edition, this is a BI-RADS-3 lesion. They had less than 500 cases. Since then, there's been a couple series raising this up to almost 600 cases. So at this point, I think it's now a BI-RADS-2 lesion. So I commonly see these little clustered microcysts and will make it a BI-RADS-2 lesion and not provide any follow-up. The next BI-RADS3 lesion they describe as a hyperechoic mass with central hypoechoic to anechoic components. They're basically describing fat necrosis or a possible hematoma. This is a good case where it's helpful to look at the mammography. If you can see a nice, lucent, circumscribed oil cyst that correlates with your ultrasound, you can basically turn this into a BI-RADS2 lesion. So again, this is very helpful to compare to your mammogram. They also talk about this refraction, posterior shadowing at the edges of fat lobules. I don't have a good picture for that. I don't tend to call people back for this because usually can resolve this with handheld views. But this is considered potentially a BI-RADS3 lesion for follow-up if you're still concerned and can't resolve it with changing your transducer angle. They also talk about architectural distortion, thought to be post-surgical change. Again, these areas of scarring could look pretty scary on one view, but the orthogonal view, it will thin out, maybe go to the skin. So most of the time I can reassure myself, especially if I combine it with the history in their mammogram, that this is just some scarring. I think this is the one case where sometimes MRI is helpful. I don't like to use MRI to problem solve, but I think in post-surgical patients, if I get an MRI and there's completely normal here, then I can resolve it and turn it into a BI-RADS2 lesion. So in terms of if you're going to do screening ultrasound, what volume can you expect? Dr. Nancy Capello was a teacher in Connecticut who was diagnosed with advanced breast cancer following a normal mammogram, had very dense tissue. She went through chemotherapy, surgery, and actually survived to age 66, and then had a myelodysplastic disease that she died from, probably as a result from her treatment. And she found it RU dense. So Connecticut was one of the first states to start insurance coverage of ultrasound for breast. And so I'm using Connecticut as your best case scenario of your volume. At one institution where they do about 27,000 mammograms, they had 3,300 women with dense breast, and 28% of them had a screening breast ultrasound. And there are several years, they've published their data over several years, and their positive predictive value is about 20%. And even on their third or fourth year of study, they're finding about 3 cancers per 1,000. So a very effective program. A large number of women use screening ultrasound. Unfortunately, even in Connecticut, some of the insurance, the ultrasound screening is under their deductible. So some people still have out-of-pocket expenses for that. So that may be inhibiting a little bit how many women choose to have a screening breast ultrasound. At the University of Kansas, they published a paper which I thought was interesting. They do a lot of screening ultrasound at this university. They were part of one of the big studies of screening ultrasound, so they're very familiar with screening ultrasound. Their patients are very familiar with screening ultrasound, but this is an interesting study because they had 3 radiologists. The first radiologist would not mention breast density in his reports, and only about 1 in 10 of his patients returned for a screening ultrasound. The second radiologist would mention the breast density in the report, and also that they may benefit from ultrasound, and about half of their patients returned. And then a third radiologist in the same practice would not only mention breast density that they would benefit, but his office staff called the patients, and about almost 90% of his patients return for screening ultrasound. So it just sort of points out the more effort you put into telling your patients about breast density and ultrasound, the more will come back. Again, this is probably the best case scenario just because their patients and facility was very familiar with screening breast ultrasound. And I think the coverage for screening breast ultrasound was very good where they were working. Similar to my practice, more patients with a family history of breast cancer or a personal history of breast cancer are going to choose screening breast ultrasound. And this program does a very good job of it. They still keep finding 3 cancers per 1,000. They don't call a lot of patients back, less than 10%, and their positive predictive value is about 30%. Other things you can do to increase your volume is just to make it easy and convenient. It's nice. A lot of my patients have their screening ultrasound and mammogram on the same day. We have a mechanism in the electronic health record for our family doctors to make this easy to order. If you can do it on an unscheduled day, say they come in for their mammogram, they go, oh, can I have an ultrasound also? That would be nice to do. It's hard for us to do this because our schedule is just so tight. A lot of insurances don't cover this in our area, so we have a cash pay option. And in fact, most patients in my facility that are getting this exam are paying out of pocket for it. So just summary, I think we can get our glass more full. We know that we can increase the cancer detection by about 40%. We know if we screen, we'll find mostly invasive node-negative cancers, which are presumably curable. We can lower our interval cancer rate, and it is possible to keep the callbacks less than 10%. In my practice, our callback rate's about 7%. Our positive predictive value is about 30%. So you can do this, find the cancers without too many callbacks and too many biopsies. This is my dog, Oreo. I've been teaching him to read mammograms. I was inspired by a study out of UC Davis, which is in our city, where they trained pigeons to look at pathology slides and mammograms. And not surprisingly, they were best at finding cancers on pathology. And on mammograms, they were best at finding calcifications rather than masses, which follows my own skill set. So I'm optimistic my dog can learn this, although he gets distracted by noises and squirrels outside my window. But thank you for your attention.